All right, good morning, everybody. Looks like several of you stayed from the session before, so thank you. For those of you who just came, thanks for choosing to come to this session. So we are going to be talking about the best evidence in telehealth and emergency medicine today, and we have an amazing panel here. So we're going to jump right in. Just real briefly, I'm Emily Hayden. I'm the Director of Telemedicine for the Department of Emergency Medicine at Mass General, and I feel very honored to be next to so many giants in the research field for telehealth and emergency medicine. So just real briefly, just for disclosures, Dr. Fisher is a paid consultant, has equity and interest in Call9 Incorporated, and Dr. Rising is a co-investigator for a study supported by Ortho Clinical Diagnostics. So this is our panel today, and I'm going to go ahead and read off their bios because sometimes I feel people aren't tooting their horn as much when they actually present themselves, and there's been amazing work done by these people. So if you don't mind, I am going to read, but in the spirit of trying to capture the amazingness of everybody. So if you can sort of wave for Dr. Jonathan Fisher here. Can you wave to so everybody knows? Okay, great. So fish, yes, fish for everybody. So he is, sorry, I'm just trying to make sure that I get into this and get the meat of everything here. So he is now the Vice Chair for EMS in the Department of Emergency Medicine. I'm sorry, this is what the morning does after a late night in Vegas, so I apologize.
Emily, do you want me to do it? I don't mind.
Why don't you do it? Can you toot your horn and I'll add things in if he doesn't put it in there. Yes.
So, I spent many years in Boston, and I am an EMS and an education guy. That's sort of my billing. I was a Vice Chair for EMS. I started an EMS fellowship. I've done a ton of EMS and sort of effectiveness research, and I also do education. About 3 years ago, I moved to get into a medical school that was starting in Phoenix. I'm at the University of Arizona in College of Medicine, Phoenix, and I am in the chair of the clinical curriculum committee over there. But I do consulting and patient safety work for a company called Call9 that's trying to figure out if we can do EMS and telemedicine in nursing homes to keep people out of ERs and stuff. That's sort of my deal.
Great, and over 40 peer-reviewed, several chapters, lots and lots out there with his name on there. So just making sure we toot our horn here. So, all right, do you want me to do it that way? You guys can present yourself, and I'll go ahead and add to as needs be. Do you want to? We'll do it that way. Changing that. Kristin, do you want to go next?
Sure. I'm Kristin Rising. I'm Associate Professor in the Department of Emergency Medicine at Thomas Jefferson University. I have a kind of diverse research portfolio which is using and increasingly using telemedicine in portions of it. And so do have an active study right now in which we're training residents and using SIM to test their skills, in which we will be using telemedicine to look at kind of expanding the potential for simulation to reach trainees and others via telemedicine, and just got awarded a grant from the NIDDK, which will be a randomized controlled trial of 600 patients with poorly controlled diabetes, and will include an arm that's getting individualized telehealth delivered medical nutrition therapy. So will be an exciting kind of really first rigorous application of telemedicine and research in our department, and we'll be looking at clinical outcomes as well as a cost effectiveness analysis of the intervention.
And just to sort of toot your horn, this is actually quite a large, this is what, over $3 million grant that was awarded this past week. So she has been very successful in receiving funding for telehealth, funding for research that has telehealth incorporated into it. So if you have more questions about that afterwards too, she would be a great person to talk to. So
is the reminder we talk about a lot, right? Is like research doesn't have to be like research of telehealth or not. Like telehealth is a care delivery model, right? And so it gets incorporated into research, and I think is what we've increasingly tried to acknowledge and do in our work.
Dr. Mohr,
I'm Nick Mohr from the University of Iowa, and at Iowa we have a center called the Rural Telehealth Research Center, and we study the effectiveness of telehealth at improving access to care, quality of care, and cost effectiveness of care, and improving health outcomes, especially in rural areas. So most of our work is focused on provider-to-provider telehealth.
and also very well funded for telehealth and emergency medicine and telehealth applications. And then I think it was over 70, I think I counted 77 articles peer reviewed too. So he's sometimes busy with stuff like this. So, and then Judd, do you want to?
Yeah, I think most of you were here for the last session, and I did that, so I'm still the same person sitting in the same seat, and I haven't published anything since then, as far as I know. But I come from a clinical research background, obviously in emergency medicine, mostly cardiology sort of stuff, but wide diversity. Actually, I can't say that it was really meant to be telemedicine, but probably my first telemedicine paper was in the 90s related to monitoring in the pre-hospital setting. And I have to go back and find the video, but my first telemedicine video that I was ever involved in was when my 31-year-old son was 2 months old, and my wife called frantic because he kept slapping himself in the face with some rhythmic movements. And I'm like, I don't know, we got a camcorder, take a picture of it, and then we'll take it to the doc. It turns out that by the time she got it to the doc, we realized he was just trying to find his mouth. So it's a great video, but I got to dig that up somewhere, because that's my first telemedicine call, and he's still alive, and he's got a big mouth, so it all worked out okay.
Awesome. All right. So we're going to be talking today about the best evidence in telehealth and emergency medicine. And so, actually, if you don't mind, Judd, if you don't mind if I put you on the spot to discuss the NQF framework, because you are one of the co-founders or co-creators of this framework. So do you mind doing that? Because we're going to be speaking to this in for the different studies we're talking about.
Yeah, for those of you that were in the last session, you heard me mention this. I think this is like critically important. National Quality Forum, they put out measures, right? And then CMS takes some of their measures and puts them into pay-for-performance things in value-based care. So if we want to, in my theory, drive reimbursement when nobody wants to pay for things, one way to do that is to have measures that say this is good quality care, and then for CMS to either pay extra or remove money if you don't meet those measures, and all of a sudden telemedicine becomes important and reimbursable. And so through a series of fortunate events, I ended up I actually put on this committee and then asked to co-chair it, which was with, people that have been doing telemedicine for 30 or 35 years when I was doing it for 2 at the time. So it was a funny position to be in, but a great chance to learn. And we created this measure framework. And at the end of the day, it's 4 domains that are important. Each has multiple subdomains, but the 4 domains are access to care, cost and cost effectiveness, clinical effectiveness, and it's not, actually it's just effectiveness, and experience. And so effectively, you cannot find a measure that might be telemedicine that doesn't fit into one or more of those domains. And we went back through the NQF database of all the measures and said, could we find anything that wouldn't fit into one of those 4 things, telemedicine or not? And most things actually fit into 2, 3, or 4 of them. So it was a pretty good framework to develop. And now NQF, when they're doing things, looks at measures as it relates to telehealth in those domains. And then my push at NQF, and they're not necessarily doing this, is actually to help to find a visit. Like there are measures that, okay, you leave the hospital in heart failure, you have to be seen in 7 days. But telemedicine didn't exist when they made that measure. So is seeing somebody by telemedicine a way to meet that measure, or is it not? So I think at some point they have to go back and say, if it's a visit, it's a visit. And it doesn't matter whether it's telemedicine or not. But as we talk about evidence today, you will hear most of these papers weren't written saying this is access, this is experience, this is cost effectiveness, this is effectiveness, but all of these papers are touching on one or more of those things. And so which is the one that you think is going to drive reimbursement in the end more than anything else? Is it going to be patient satisfaction? No, right? So it's going to be, is there an element of clinical effectiveness that's cost effective? And so as we think through these studies, or if those of you in the audience are researchers, think how can you help inform that process? Because that's the way we're going to be able to motivate change.
Great. So yeah, so we're going to use that framework when we're just describing the different studies. This will be a little bit different than some of the best evidence presentations and other and other rooms maybe, that we're not going to spend as much time on the details of the specific data, the specific results, and the methodology, but touching upon sort of what you guys think has sort of been interesting about the study, if you thought it was, you know, was it done well or not, and then also what that spurs for like future studies too. So we also decided to do this in a little more of a framework where we're going to touch upon the different types of telemedicine or telehealth that occurs in emergency medicine. So we're going to go through and each one of our panelists is going to speak about either provider to provider, the call 9 approach, provider to patient, and the teletriage. So each one is sort of taking that on as the at least domain that they're going to speak about. And feel free, we're going to have them present about this, but also any questions from you guys, please feel free at any time to raise your hand, and we'll make sure we try to capture everybody's questions. So I think starting off, I think we're going to have Nick, if you don't mind, on the provider to provider, sort of the evidence that's out there, if you don't mind starting off.
Do you want me to go through all of them, or are we just doing one? So you want me to go through one of the papers and then somebody else? How do you want to do this?
Why don't we do this? So we'll, he was just asking if we should go through all, I think maybe all the papers that you had on that domain, on provider to provider. So that right now, provider to provider hat is on. This is what we're going to speak about.
Right. Just make sure that everybody can hear me, right? Okay. So I think many of you know this. Provider to provider telehealth in emergency medicine is a connection between an emergency department with typically some type of hub that is providing telemedicine services, and those hubs can look a little bit different. But I picked a couple papers that I think kind of encompasses some of what would be the strongest evidence right now. The first paper is a systematic review of telemedicine applications in emergency rooms by Marcia Ward. This is a systematic review that was done now a couple years ago, where the team who was doing that review went out and did sort of a scoping review and then a systematic review of applications for telehealth in emergency medicine. And then they described that, and the goal really was to see what has been published and what outcomes have been reviewed. So they identified at that time 38 papers that had been published in that area. And there was heterogeneity in who was staffing the telemedicine network, what types of hospitals the telemedicine connection was done between. But they classified those papers into one of three groups. The first was telemedicine applications in general emergency departments. The second was in applications between providers in telemedicine with minor treatment clinics. Most of those were British studies. And the third was connections between an emergency physician and some kind of specialist. And I think that one of the big findings for me in this paper was, number one, that there's not a lot of data published on that. I think that there's been a fair amount published since that time. The second big finding was that, you know, many of the papers we're talking about, as we talk about kind of the NQF framework, some about patient experience, some about cost a little bit, but not really a lot about cost effectiveness or really a comprehensive view of cost, and a little bit on access. But many of them were single center studies that were kind of pilot projects that were pretty small. There weren't a lot of big multi-institution, multi-center, multi-network studies to understand what the effect of this would be if it goes to scale. And so when I read that paper, I sort of see that as identifying a real gap in the literature. The other thing that was kind of discussed in that paper was the issue of publication bias, right? That many of these are kind of small studies with a few patients in one center, and they're all kind of resoundingly positive that telehealth can do everything, but that there is a real dearth of real data to base that on. I don't know if you guys have any other thoughts about that.
I'll just give Marsha credit. Marsha was the co-chair with me at NQF and runs the center that Nick's at, and has made a major dent in research in telehealth. So it's just worth pointing that out.
Right. The second paper that I was going to talk about is actually not an emergency medicine paper, but I think it pertains a lot to emergency medicine. There have been several papers looking at provider-to-provider telehealth, especially in rural America, trying to trying to find what the value is of that. And that value is sometimes measured in quality, sometimes it's measured in avoided services, and avoided transfers, avoided regionalization, avoided testing is one of the places where a fair amount of that work has been done. Some of the papers that we've published have looked at that too. But for the most part, many of those papers have been null, meaning that they have shown that sicker patients have telemedicine used, but that controlling for a bunch of things, typically that doesn't change who gets transferred to tertiary care centers. It doesn't change who is admitted to the hospital. There's a paper that's written by Ethan Cooperman and Kevin Glenn called The Virtual Hospitalist. And this is, even though I was just talking to you about kind of single site studies that are not huge and kind of tell people's experience, this is a really interesting study that looks at the use of telehealth in hospitalized patients. And the reason that I think that it's interesting is because they did some of the same analyses that we've done in emergency departments. And in some of the qualitative work that has been done in emergency medicine, people have said, you know, we want to put a telehealth program in place so that we can keep more of our patients locally in rural hospitals or community hospitals and not transfer them to tertiary care centers. And, you know, we want to reduce costs and all of these other things. But when we go back and evaluate those programs, in many cases, people will say, well, even if I in the emergency department think that something can stay here, I don't have anybody to admit them to. And in many cases, I didn't need a telehealth provider to tell me how to treat this patient with pneumonia, but I don't have a provider here who's comfortable taking the patient, and that issue of kind of not being comfortable is the issue. So this virtual hospitalist paper was a single center study that was done using a hospitalist program where they incorporated tertiary hospitalists to round on patients twice a day with the help of an advanced practice provider in a rural hospital. And they had a number of different outcomes that they were looking at, but the things that I think were impactful was that the transfers from the emergency department to a tertiary care center dropped from 17% to 10%. Okay, that's a reasonably large effect size for something that actually wasn't even implemented in an emergency department. So it sort of shows, like what we see in boarding, that the effect of telemedicine in a hospital on the emergency department may not be in the emergency department. It also, they were looking at some quality metrics. They were looking at the number of patients who decompensated after they were in the hospital, which fell. They were looking at the number of patients who transferred from inpatient status, which also was lower. They didn't see significant differences in length of stay, census, transfers after admission, which sort of parallels some of the tele-ICU literature. But I think that it's a novel application of applying a telehospitalist model really to try to decrease the number of transfers and improve the financial viability of a rural facility. If you guys have any thoughts about that.
Actually, I love the way you said, I want to scribble down the exact quote, how things not in the emergency department impact the emergency department, right? Because that's our curse.
Right. I think it's one of the ways that we can think about using telehealth to influence us that may not be within the walls of what we do. All right, the last paper that I'm going to go through is a pediatrics paper. This is an economic evaluation of pediatric telemedicine consultations to rural emergency departments. This is a paper out of the Davis Group, who has done a fair amount of pediatric critical care telemedicine for a long time, been well funded, and has published a number of papers. And this is it's intended to be sort of a comprehensive cost effectiveness analysis using robust Markov modeling to estimate the value of telemedicine. Now, the network where this study was conducted is a network where pediatric intensivists perform teleconsultations for patients in small hospital emergency departments. And so it's primarily focused at the sickest kids, although it's used for some patients who aren't sick, the way that I understand the network. And this decision tree cost effectiveness analysis goes through and it uses some data from some large claims-based data sets to estimate what avoided cost might be. And they also kind of estimate what the cost of providing the telemedicine service is. So They say that the economic evaluation compares similar acuity triage patients who receive telephone consultations to a more comprehensive video-based telehealth presence. And like we probably aren't surprised by, when they go through and kind of do their analysis, they estimate that the cost of telehealth encounters in their network was a little over $3,000 per patient, but they see 30% fewer transfers because of that, and it avoids cost in emergency departments, and it avoids cost in other places. One interesting thing about this paper was that they didn't include in the cost analysis the cost of the provider, because they were saying that in a tertiary medical center, there's going to be a provider taking telephone calls anyway. So this sort of depends on the provider being sort of free, or at least the same cost on either side of the analysis. But the thing that I like about this paper is that many of the cost papers done that have to do with telehealth are done where they sort of will make some big assumptions about, we decreased our transfers by, a lot, and so we're pretty sure that everybody would have followed our recommendations if we told them they shouldn't transfer patients. We're pretty sure that all of the patients who we didn't transfer did fine and that there were no bad outcomes. But in this paper, they really used a robust Markov modeling decision analysis to try to estimate what the real incremental value of this was. I think we could talk about the appropriateness of some of the assumptions, but I think that this is what we need to be moving to in telehealth research. I think that when we're talking about innovative care delivery models, coming up with what our innovation is and what the counterfactual is really important. Understanding that telehealth models often don't function in the way that we design them to be. Understanding that wild-type care sort of seeps in even in innovative models. And I think that that's really what the authors were trying to estimate in here. And I also think that trying to apply this type of methodology to other applications in emergency medicine or in diabetes care or in triage or in these other types of models to really build the case robustly that telehealth is or is not beneficial. And then also recognizing that each telehealth model is very different. So the experience that they've had in their model in California certainly has been robust. That doesn't necessarily mean that if somebody hangs their shingle in another state with a different system, with different staff, that they would have the same outcomes. But it does give us some confidence, I think, that we have a framework to analyze that type of model. If you guys have other thoughts on that.
Could you explain Markov modeling? No, I'm just kidding.
Anything else from the panel? Anybody want to disagree with it?
Nope.
Any questions?
Yeah.
So thorough, Dr. Mohr.
I will take one point in the comment that, determining whether telehealth is or is not beneficial. That's a tricky phrase because, one of the problems with telehealth is the benefits are to the patient, in theory. They may not be to the payer. And the outcomes, I don't think, are going to be better. They're going to be nearly as good. So nearly as good, less expensive, and way more convenient is kind of a nice thing. But if I'm the payer, it's not beneficial. If I'm the patient, it might be beneficial. And so I think we have to be careful about setting expectations. And my expectations, a little statistical term, is that telemedicine is non-inferior to regular medicine. I could do more or less the same thing with some advantages to the patient, because if the patient just doesn't need to drive anywhere, that's pretty cool to me. But again, Blue Cross probably doesn't care about that. In fact, they probably prefer they drive somewhere because a 30% no-show rate means they save 30% of what they would have paid that day. So it gets a little tricky.
I think that that's true. I mean, the promise of telehealth has been that people have said for a long time that we can kind of redefine this kind of triangle of healthcare, right? That we have cost, we have access, and we have quality, and that through technology we may be able to improve access and maintain cost and quality. I think that if telehealth is beneficial to society writ large, it's fine for there to be improvements to convenience for patients. That's really better access, right? And if we can provide better access with not higher cost, that's probably a benefit. I also think that not every application of telehealth accomplishes that, right? So there are certainly applications out there where people have good ideas and we don't realize it.
Well, I just think you said not before. You can't increase access if you frequently that have certain costs, right?
Wait, say that again. There's stuff wheeling by. I honestly can't hear.
Said you can't increase access.
You can say you can increase access and decrease cost of care, right? However, unless you decrease the cost of visits, I mean, almost all healthcare systems, even in Canada, the reason they keep healthcare costs down is they have barriers to access. And insurers create barriers to access. There's copay, you can't see the doctor, network, can't see the card for doctor. People even do it. And that's how they control costs. And so if you increase your access, insurers are just right, you're not going to like it. But I think it's a big challenge unless you take less for visits. Are you going to pay for it? And I think if you're looking at trying to see how this will roll out, it's really a good, it's all about what incentives are. What are the financial incentives for the providers and insurers?
Well, so you do have lower cost for many of the visits. It's a lower cost per visit rate for the telemedicine. It is just the question of if it balances out, if you increase access so much that you don't really make a dent on cost, right? Or if you can have that visit on telemedicine, and we'll talk about it a little more with direct-to-consumer, but if you can have that visit on telemedicine and potentially, divert even a small proportion of patients who are going to the ED, then you can still have a lot of telemedicine visits until you actually are, seeing increased costs with them. So it's not a super simple answer in there, but it is important to look at. Yeah.
So we've been messing with this for a long time. We actually, I think we finally hit the nail on the head and drove up our adoption and probably decreased our costs. But we're unique. We have 30 to 50,000 employees and dependents, and what we did is we did benefits design, and we basically said for the people who we are self-insured, so it's our cost, if you call Jeff Connect first before you go to the ER or urgent care, and our providers who are ER docs send you to the ER or urgent care, we will waive your copay, which is $50 for urgent care and $250 for the ER. Now, what we did in that is interesting. We drove up our volume about fourfold overnight, and we have, people calling from the driveway of the ER periodically that need to go, sort of like asking for permission to go. But before we did that, only 5% of our patients were going to the ER, and 2/3 of them were admitted or getting a procedure. Our number of patients going to the ER has now gone up dramatically because we're only getting, like that fourfold increase is all people who wanted to go to the ER. And what we've done is we've cut out a whole boatload of them, we think. And so trying to do an economic analysis on how much money we save in our employee pool will actually be something that we do at some point. But I think in that model, we drove up access to care and we probably drove down costs.
And Fish, and last comment here before we switch to the next one. So yeah, Fish.
So that's exactly the model, and how you're going to control costs. If you can reduce utilization, reduce complications, and move people into alternative care models, it's going to save money. So the access is going to drive costs. If you just let people, use it at will, but don't try to improve any of those other features, it will definitely add expense. And that's the fear of CMS, of payers, that they're just going to give you this new drug or new tool or new intervention, right? It's why I can't use IV Tylenol in my ER, because if I give you a new shiny toy, you're going to overuse it. If I give you telemedicine, you're going to overuse it. So the models that we have to move is a value-based model, and I think Judd's point of how he's doing it is exactly the right way it'll work.
Yeah. So that sort of leads in a little bit, I think, to the next sort of domain area of telehealth and emergency medicine, and we sort of started talking about a little bit, the direct-to-consumer and direct-to-patient. So, Kristin, you want to take that off now?
Sure. So I have just a couple articles to go over with you. The first are based on kind of review of large insurance claims databases, and I think reflect the limitations for much of direct-to-consumer telemedicine that's happening right now, is that they're happening with for-profit companies that have no relationship or kind of association with academic medical centers and are not connected into the system. And so, you know, we could talk quite some time about what we have going on at Jefferson, but when we have direct-to-consumer at Jefferson, we have patients who, if they've already been in our system, we are in the system like anyone else, looking at what's happening with them, what visits they've had recently, what their medical problems are, what testing has showed. We also engage with their providers as part of that system. And so these studies that are looking at someone called TellATree or American Well or one of the other big national organizations are kind of looking at a different entity than what might be a grown academic center. But the first one just came out this year, actually, is looking at antibiotic prescribing during pediatric direct-to-consumer telemedicine visits, published in Pediatrics in this year by Kristin Rising et al. And it's primarily looking at the domain of effectiveness. And so they were looking at kind of comparing the quality of antibiotic prescribing for children for presenting with an acute respiratory infection in one of three places, so a telemedicine visit, urgent care, or primary care provider. They used 2015 to 16 claims data from a commercial health plan. That health plan has a contract with a single direct-to-consumer health single direct-to-consumer organization, and so that was who the patients were using. And they did matching of the sample based on demographics across the three different use cases. So they were comparing first all acute respiratory infection visits for which there were any antibiotics prescribed in each of the three care settings. And then they were looking specifically per care setting, the proportion of the visits who had guideline concordant antibiotic use. And so they had, in this sample, they had kind of 4,000 and change telemedicine visits. They had about 384,000 urgent care visits and 485,000 primary care visits, and found that antibiotic use was highest in telemedicine across all visits, and guideline concordant care was lowest. And so the antibiotic use was 52% in the telemedicine visits, 42% in urgent care visits, again, these being matched visits, and 31% in the primary care setting. Guideline concordant care kind of in the opposite direction, right? So it was 59% in telemedicine, 67% in the urgent care, and 78% in the primary care offices. You know, it was interesting to them. The similar group had done the kind of same analysis and look published separately. I don't have the article specifics here, but did the similar analysis with the same data set from these insurers for adults and found pretty similar outcomes across the populations. And so, like, a lot of hypotheses in looking at, right? So probably a lot of the direct-to-consumer plans really especially don't have pediatric-specific providers. And so really going to the value-based care of the pediatrics needs to be considered and looked at for the use of these plans. There had even been recommendations, right, that people shouldn't be using the direct-to-consumer kind of plans for kids under 2, and, you know, about 5% of the visits were for that population. And that also there may be pressures that parents especially, kind of those pressures can't be withstood as well on the telemedicine of just parents being super concerned about their kids, or higher, you know, thinking around ear infections or things that can't really be analyzed on the direct-to-consumer kind of model. And so that was their, you know, an analysis out, and we'll certainly need some further looking. Just came out this year. A second one by some of the same authors, some different, is direct-to-consumer telehealth may increase access to care but does not decrease spending. So this was by Ashwood et al. In Health Affairs in 2017. It was looking both at kind of access and cost. And so they were using a commercial claims data set, Blue Shield of California HMO data for over 300,000 patients from 2011 to 13. And then they were exploring patterns of utilization and spending for, again, acute respiratory infection, using this as the focus because this is the most common condition for which patients overall seek telemedicine care. And so they looked at two cohorts across that data set. They looked at those who did and did not seek telemedicine care for an acute respiratory infection. They used propensity score matching, a 2-to-1, so 2 non-users to 1 user of telemedicine, and looked at trends in non-telehealth visits for those two groups, kind of across a time frame, right? And so, like, trying to figure out if other utilization of health services changed at all based on having a telemedicine visit. They concluded that almost 90%, so 88% of telemedicine visits appeared to be new visits, so did not appear to be replacing other visits that might have happened. This is opposed to other data that Prior that I had suggested really it was in like the 10 to 20% range, so this was a much higher kind of new visit analysis. And while net annual spending for acute respiratory infections increased about $45 for each telemedicine user, was their kind of conclusion from the cost side. So really concluded that while telemedicine may increase access for certain users, it may also overall increase utilization and spending. Was kind of their conclusion from there. Limitations, though, it was one health plan that had very good coverage for patients, and so there was no reason for the patients necessarily to feel like they needed to decrease use anywhere. Certainly, it may vary for uninsured or underinsured, for high deductible plans. It also was just for one illness, right? So just for acute respiratory infections, and looking across other illnesses would be an important part of this analysis. So those are those two kind of looking at national plans, and then just have one other I was going to talk about, which was actually an initial, certainly we need some more robust analyses, but was an initial good first look that actually was done by our team at Jefferson, looking at, and the title of this one is On-Demand Synchronous Audio-Video Telemedicine Visits Are Cost Effective, was our title for this. It was published in American Journal of Emergency Medicine in 2018 with Garrison Nord as the primary author. And the question for us was looking at, does telehealth increase cost, right? There have been some studies to suggest that. And so we looked at patients who had on-demand telehealth visits with our service. So again, this is academic emergency medicine providers at Jefferson, who the general public can call, or certainly inclusive then of all of the patient population at Jefferson. And so we surveyed patients at the time of the visit to look at what patients would have done if they hadn't called telemedicine, asked them, would you have done nothing, gone to your doctor's office, gone to an emergency department. 16% of them said they would have done nothing. 34% would have gone to a doctor's office, 33% would have gone to an urgent care. And then we surveyed them at a period after, so days after their visit, to find out what they did after, right? And so 74% of them did nothing further, did not seek care somewhere else for the complaint. 15% went to a doctor's office, 5% went to the ED, and 4% went to an urgent care. And so we use cost data from the literature. This was not actual cost data from these visits applied as a kind of primary limitation of the study, but did conclude across that there were net cost savings of anywhere in the range of $19 to $121 per visit. Significant limitations to the study, though. We really had no real patient outcomes incorporated into this, aside from patients just reporting where they went. There was not a true cost effectiveness analysis of any sort. And we weren't using actual cost data, right? It was cost from the literature. But it was an important first look at how this might actually be impacting patients within a health system. Do you guys have anything, especially Judd, who lives on this paper as well, anything to add to?
That was a great paper.
Any other of you have any of the other thoughts for the direct consumer literature?
So literally while we're sitting at this table, I got a letter to the editor to say, hey, do you want to sign on to this on the pediatrics paper? And so I just skimmed to see what it was, and she was talking about the paper, and I had this at the same time. So if you saw me being rude, that's why. And actually, there's a great point in the concluding paragraph. Telemedicine doesn't treat pediatric patients. Doctors do. And so if these doctors are overprescribing antibiotics, they're just crappy doctors. You should see a different doctor. It has nothing to do with telemedicine. We have the same problem in the outpatient setting, right? So the medical care is delivered by a doctor, not by a video. The video is the way you do it. And I actually have this quote that I like, that part of it is, when you go to the hospital, we don't ask you whether you got your care on the 3rd floor or the 5th floor, right? We don't care where you got your care. And we don't ask whether your doctor's wearing contact lenses or regular glasses or no glasses or how they see you. They just take care of you. We don't care whether you document in Epic or in Cerna. We don't care. Quality care is quality care. And so this was maybe bad quality care. Has nothing to do with telemedicine. It's the providers.
I will say anecdotally, from working the other side of being the on-demand doctor, I find it a much easier conversation with patients to not give them antibiotics for things when they have not been sitting for hours, paid large copays, had all sorts of other things, and to have that education with them and kind of explain what our kind of rules of the road are for that. I actually hope patients leave the visit better educated and satisfied enough in the fact that they've been able to talk through this and, understand, hopefully, the reason that antibiotics often are not indicated.
And there is a publication by Dan Halperin Rudder that shows the same group of docs working in the ER urgent care center and telemedicine, what their antibiotic utilization is for sinusitis. And although it wasn't statistically different, the most compliant with choosing widely guidelines by absolute value was actually telemedicine.
So, just one thought about telemedicine as a provider, and maybe it's my own weakness doing it. It's a little bit harder to do the physical exam, right? And there's a little bit less of the show of the testing of things that you get in the ER. So when you're trying to have that conversation about not giving antibiotics or not doing something, there's a little bit of that debate about, well, you didn't really do this, or I didn't get my prize for showing up in the ER. So it becomes a little bit of a challenge. But telemedicine is a tool, and like Judd says, if you're a bad doctor, telemedicine's not going to make you better or worse. It's just what you are. But there are challenges, right? So it has to be the right tool, right? So it's hard to look at someone's ear using telemedicine unless you're doing it in a provider to provider or some sort of facilities anywhere you have a camera set up to do that. So if you're going to do otitis visits via telemedicine, it's a hard sell. So that's the challenge. I get the difficulty of it.
So I haven't been as good at the Taskmaster on time that I should have been, so we are getting very close to the end. So I do want to make sure we get a chance for the teletriage and for the call 9. So Fish, do you mind going ahead and speaking about the call 9 model and any research on the, maybe give a brief introduction of what call 9 is too, please.
So I'm going to sort of do very quickly and skip to the heart of the challenge and do it sort of in the model of the NQF sort of form, right? So what we do in telemedicine in nursing homes is there are these patients that nobody really cares for at night, and less people care for during the day. There's a lot, most people, the doctors come once a month, things happen, and how do you provide care for those patients? One of the challenges in the nursing home is nursing home nurses are great at what they do, but they're not great at acute care medicine, right? If you took a nursing home nurse and put them in your ER, you might have a challenge there. So that's sort of the world we work in. So what we did to help us with that challenge, there's some people who just do telemedicine directly in the nursing home. What we've done is we've added a paramedic-like entity in the nursing home visit to act as an extra pair of hands and resources, and it's dramatically improved our ability to do things. But to talk about the model and the literature quickly, right? So access, clearly we're going to increase access. We're putting providers there. We're providing open, just like provider option. Cost is our whole goal and model is that yes, you're going to pay us to do these visits, but we're going to try to reduce something down the road. But the challenge is, are you actually spending more in the nursing home to do it? So are we ordering extra tests because we can't examine the patient as well? So that's part of what we're trying to get at. But how do you get a cost basis in a nursing home where they if you look at the cost of an encounter for a nursing home patient, they may get 18 to 30 different people billing on that patient, right? So you call an x-ray company in, you call a CT, send them to an outpatient center for a CT. The phlebotomist, so it's a very hard challenge to figure out the cost basis. So people do all these modeling things in terms of effectiveness. What's your outcome that you really care about? Is it just that you didn't send them to the hospital? Well, the concern is, did you not send somebody to the hospital who needs to be there? And they call that care stinting in the vernacular of insurance companies. But one of the phenomena that we see, not just with us, but all the providers, if you send less people and allow palliative care to take place and do better palliative care, more people are going to die in the nursing home. Is that a good thing, a bad thing, right? And so that's a challenge. And then experience. Who's experience, right? There's lots of papers saying that everyone likes it, right? The Mikey likes it. But those are usually the nurses and the staff. But half of our patients have dementia, right? You hand them a Press Ganey survey, they turn it into a paper hat. I'm not trying to make fun of them, but it's just the reality of our world. So most of our experience data actually is with the families and not. And if you look at their but there's really only one major paper out there that's a paper about chest, and I keep losing it. I apologize. It looked at one of the models with just telemedicine in the nursing home, and basically they said, look, we saw a bunch of patients, and we didn't send a bunch to the hospital. We did good. And then they said, because we didn't send, and I can give you the numbers, but, because we didn't send a bunch to the hospital, we saved that cost. So it's a good paper, right? It kind of gives evidence of what we think, right? We know that people are sent unnecessarily, but the challenge is how many of those patients would have actually been sent out before, and getting to the numbers or that reduction in transfers is really the reduction in admissions cost savings. And how do you get there? Because the data is so poor. It is amazing. Half the time, we as the telemedicine provider are telling the nursing home that the patient's not actually in their facility at the moment, because they'll send them out to dialysis. Dialysis says, oh, yeah, they don't look good, and sends them to the hospital. Now, nobody told the minute that the patient's that didn't come back from dialysis. So the record in the nursing home looks like they're still there. So there's lots of bad data in the nursing home that we struggle with. So there's a lot of challenge, a lot of great work to be done, a lot of very cool things, but you have to redefine your outcomes, and you have to think about how you're going to get to cost data. That's pretty much a nutshell.
I'll do a 1-minute thing through TellATree just so we hit that, and I won't go over. I had 4 papers lined up, and I'll just, from an access point of view, every paper that's looked at, it shows teleintake, TellATree reduces left without being seen. So what is TellATree? Just for those of you that came in after the last session, it's basically you show up in the ER and we see you remotely by a doctor who's not actually in the ER. We write orders on you after doing a very, very brief history and physical. We write orders and we write a note, and then we send you through to wherever you're going to go in the back of the ER. It's not direct triage. It's not the same as direct to consumer. So again, every paper shows great reduction in left without being seen, which actually is revenue, right? Because if you went into Walmart and then you walked around the store and said, yeah, the cashier's line's too long, I'm just going to go home, they lose money. We're really the same thing. We got everybody working there. We're just letting money walk out the door. It doesn't make sense. So that's the access issue to it. The cost and cost effectiveness issue is our throughput times are a little bit better. Our left without being seen are reduced quite a bit. So it funds from a cost and cost effectiveness point of view. It's easy. It's the only thing I know in telemedicine that's relatively easy to build an ROI around, because you know how many people you keep around. In terms of experience, both on the patient side and our provider side, actually the experience is great. And maybe on the experience side, we haven't done this study yet, but we all know as physicians, if you work in urgent care or you work in the peds ward, peds unit, you're going to get sick next week, right? I don't catch anything when I do teletriage. It's really, I actually do believe that our illness days probably go down on the provider side because I'm staying away from sick people. So that would be an experience thing that actually could be measured and assessed. That's kind of cool. And on the effectiveness side, there's actually a bunch of papers that have looked at effectiveness in a variety of different ways. One did direct observation of nurse triage versus teletriage and showed, yeah, it looks like they got everything right. Not a great paper in 100 patients, but did that. One paper looked at how often were the orders changed when you got to the provider in the back, and it was less than 1% were changed. We did a quick run. It's not published yet. I don't know if the data is actually accurate, but we did a quick run when we went to a provider in intake and said, did we drive up test utilization? And we did drive it up between 1% and 3%, depending on the test. I don't know if going to teletriage as compared to provider in intake dialed up tests or down tests. But I also do believe we're more compliant sometimes with choosing wisely guidelines over telemedicine because, again, you're just a little further away and the call's a little quicker and you don't have the same pressure from the patient, as Kristin was talking about. And then on the effectiveness side, you're getting seen by a real doctor in the back and you're getting your x-ray and labs faster. So it's likely not to be a decrement in effectiveness, so it should be at least as good as. Kristin Rising, sitting over here, has one of our great saves in that she diagnosed, got an ultrasound, and sent an ectopic to the OR before they got a room in the emergency department one day. So clearly a good N of 1 for an anecdotal thing. And we had a Carter Aquina who made it to the OR, got their MRI, and to the OR before they got a room at one of our other hospitals. So there are some anecdotes that when people are waiting really long, we can do a little more than just say, oops, you're sick, go to the back and help out and identify some sick people. All the data across all the studies, basically give it at least equal, if not better, in all 4 domains.
Great. So just one little thing before we open up for more questions, just for those who didn't know yet. There is a consensus conference next year, is Telehealth and Emergency Medicine, so it's going to be diving more into what gaps exist and where we need to prioritize our research in the field of emergency medicine. So please remember that. I have to catch a flight, so I'm going to let you guys ask some more questions. I don't see another group coming in just yet, so if you want to ask questions of the panelists, I'll let you guys self-rule. And if not, thank you again for your time here, and sorry that I have to run.